Hi everyone, this is Dr. Vinod Sahu, practicing physician and diabetologist at Dr. Vinod Sahu Multi-Speciality Hospital, Jhansi, UP. So today I am presenting a case of diabetes who is middle-aged patient around 56 years with high HbA1c and diabetes of short duration, that is around 4-year diabetes. So coming on the case, basically the approach of diabetes had changed many more in last decades or two. Initially, as the beginning was there, we started treatment of diabetes by diet, exercise, and then medicine. And initially, the dictum was that we start with metformin, and then after 3 month time, a patient is not controlled, then we put patient on sulfonylurea and still wait for another month. And in the due course of time, there is a hit and run approach. So in this approach, the diabetes is not at target as we desire. So the concept of combination therapy has started now in last decade or two. To start with, patient has to be controlled very tightly with respect to his blood sugar level, because the what concept is of legacy effect, that is, once patient is initiated on oral hypoglycemic agent or any anti-diabetic therapy, initial 4 or 5 year of diabetes are very much important for prevention of macrovascular and microvascular complication in the long run. So if we control diabetes very tightly in initial 4 or 5 year of patients, the outcome or the rate of complication will be better dealt with, and the initiation of complication will be delayed for 1 or 2 or 3 decades later. So patient will lead its productive life for another 4 to 5 decades. So coming on this particular case of mine, patient Mr. AR, who is 56-year-old male having diabetes of 4 year duration. Patient is obese, hypertensive, hyperlipidemic, and having history of coronary artery disease, as patient was labeled as a patient of angina. On examination of this patient, we found his BMI of 30 kilogram per meter square body surface area, that is obese, blood pressure around 140 to 94 millimeter mercury, having pulse rate of 68 per minute. On measuring lab measurements, his HbA1c is 8.8%, eGFR 74 ml per minute, LDL cholesterol 90 milligram per deciliter, HDL 35 milligram per deciliter, triglyceride around 280 milligram. His AST and ALT level is 68 and 54 respectively, means patient is having some component of NAFL. Currently, patient is taking metformin 1000 milligram BD, Remipryl 10 milligram, Atorva 20 milligram, clopidogrel 75 milligram once daily, along with aspirin, metoprolol 100 milligram OD, and hydrochlorothiazide 12.5 milligram OD. And also, this patient was taking glycerol trinitrate 2.6 milligram twice daily. So this patient is of diabetes, hypertension, coronary artery disease, and some component of nephropathy. Basically, his eGFR is 674, so it is not a bad candidate, but it is stage 1 chronic kidney disease where the eGFR is 60 to 90. So patient is also having some component of nephropathy. Urinary albumin creatinine ratio, that is UCAR ratio, is it is around 350. So it is in the macroalbuminuria range. Coming on patient profile, patient is having short duration of diabetes, that is 4 to 5 years of duration. He is middle-aged patient around 56 years, and he was diagnosed as a patient of cardiovascular disease. Basically, he is having angina. Patient is obese, having BMI 30, hypertensive, hyperlipidemic, and history of coronary artery disease. Now, how can we help this patient for ongoing his life, so that in the next 3 or 4 decades he should live a productive, fruitful life? So what ADA recommends? Basically, American Diabetic Association recommends that HbA1c should be less than 7 of all non-pregnant adults. And after reduction this HbA1c, that is getting target of blood sugar, we have to tackle this patients as a whole, as in toto, because after controlling this HbA1c or blood sugar, our priority is to reduce the weight of the patient, or the drug should be given which should minimize weight gain, and the medication should be like this, that there should be low chance of hypoglycemia and tightly control of blood sugar, and the medicine should be like this, that reduces risk of heart failure because this patient is of coronary artery disease, hypertension, with diabetes. So there is chances of heart failure. We should choose the medication in the diabetic armamentarium that reduces risk of heart failure, atherosclerosis, cardiovascular disease, along with progression of chronic kidney disease, and it should be somehow it should be cost effective also. Now, what action we have to take is in this particular patient. Basically, this patient, Mr. A, he want to start another medication, but this he fears that already he is taking so many of medicine. So I think that fixed dose combination could make his better compliance, and after making a good compliance patient, this medicine can be put to this patient. He is also fear that the medicine should be so that it should improve side effect profile also. So ultimately, our goal is to give this type of medicine to these patients. Basically, diabetes is such a disease where comorbidity is that patients of diabetes, most of them are hypertensive, having cardiovascular disease, having chronic kidney disease. So we have to give the drug which addresses all needs of the patient, and it should give a mortality benefit to the patient. After discussion of this what type of medicine we are having currently, which benefit the most of this patient. So on seeing all the group of medicine anti-diabetic, which should reduce all risk of future diabetes, option is in this patient to add GLP-1 receptor agonist or SGLT2 inhibitor, so that these medicine, they cater MACE score reduction, hypertension, hospitalization of heart failure reduction, cardiovascular death benefit, and CKD progression. To tackle all these things, these two group of medicine are better. But because of being GLP-1 receptor and injectable therapy and the costly one, patient prefer SGLT2 inhibitor. No doubt, this is the group of anti-diabetics which is benefiting the patient by all the means. SGLT2 inhibitor is such a class of medicine of anti-diabetic portfolio which is helping in each and every aspect of diabetes, whether to control lipid profile, whether to control weight of the patient, whether to check the progression of chronic kidney disease, whether to improve the weight of the patients. So this is the drug which is benefiting a lot to the patient. It is having lower risk of hypoglycemia. Basically, it lowers glucose by inhibiting urinary glucose absorption. That is, it causes urinary glucose excretion by inhibiting SGA, sodium glucose cotransport 2 inhibitor in proximal convoluted tubule. And the salutary effect is its ability to act independently of insulin secretion and action. Basically, the effect of SGLT2 inhibitor is not on the pancreas or not the alpha cell of the pancreas in secreting the insulin. This acts on proximal convoluted tubule of kidney, where it causes urinary glucose loss. Thus, it causes glucouresis also, natriuresis. So, it's help in controlling blood pressure also, and it is suitable for all the group of diabetes patients. Any stage of diabetes of any duration, this will help. Now, SGLT2 inhibitor, no doubt it is a very effective drug, but probably it will not control independent. This is SGLT2 inhibitor is the group of drug which helping cardiovascular benefits and renal benefits. So in both the segment where cardiovascular disease is there or chronic kidney disease is there, this drug is the first, and this can be given to the patients who are having EGFR up to 30 ml per minute. So this drugs helps a lot. Maybe in initial few weeks, it decreases some EGFR level, and but ultimately in the long run, it decreases the progression of chronic kidney disease. And to help this SGLT2 inhibitor, we because in EMPA red outcome, all the risk reduction is there with the SGLT2 inhibitor, but along with metformin and SGLT2 inhibitors, we need some other medicine also to cater all the needs of the patient and do the tight control of blood sugar. So another option is DPP4 inhibitor, and especially this linagliptin, because in Carmelina and Carolina trial, this is a medicine in the gliptin family, which is cardiovascular friendly and renal friendly, because the excretion of this linagliptin is by hepatobiliary routes, so it is very much renal friendly and can be given to each and every stage of chronic kidney disease without any dose adjustment. So to combine this linagliptin with SGLT2 inhibitors like empagliflozin, it is supporting, it is supplementary or complementary to both because the pharmacokinetics are almost same and the level of action is different. At the one arm, these SGLT2 inhibitors are working on the urinary glucose excretion at the proximal convoluted tubule of the kidney. On the other arm, this DP4 inhibitor, that is linagliptin, works on incretin hormone. Basically, it's cause elevation of incretin hormone in the gut and it augments glucose-dependent insulin secretion and inhibition of glucose output or inhibition of glucose release by action on GIP and GLP level. So this is acting on the gut level, DP4 inhibitor, and SGLT2 inhibitor is acting on the kidney level. So basically, insulin action or insulin secretion is not disturbed by this both the drugs, and these both drugs are complementary to each other, and the benefits in respect to cardiovascular and renal patients, and in one fact that the side effect of SGLT2 inhibitor, that is genitourinary infection or yeast infection in genitalia, melanitis or vaginitis. This is also tackled if you combine SGLT2 inhibitors with this DP4 inhibitor like linagliptin. Maybe due to tight blood sugar control or the mechanism could be anything, has to be sought out, but the patient is benefited by this combination. So basically, this patient, Mr. AR, if we combine this EMPA and LINA combination, because this combination is available now in the market and being a fixed drug combination, the cost effective combination is this. Compliance is better because once daily dosing, cost effective because if you give two drug of LINA and EMPA separately, it will doubly cost. So seeing this all the benefit, this patients, Mr. AR, will lower their risk of heart failure, will lower the risk of chronic kidney disease, will lower the risk of cardiovascular death. So ultimately, or 4-point MACE reduction is there. So ultimately, this is the combination which also benefits their control of blood pressure also, and also it will control lipid profile status also. In addition to decreases the weight gain or it will minimize the weight of the patient. So my stand is to start with this combination, and this benefit will be seen in the near 6 months or 1 month or 6 months or 1 year time. So this is all from my side. I think this approach of the patient to a diabetes, it will help to control tightly the blood sugar in the initial 4 to 5 year of diabetes, so that rate of macrovascular and microvascular complication will be minimized, apart from controlling all cause mortality like cardiovascular death and mortality due to kidney failure. This is all from my side. I thank you for the giving me this platform to talk. Thank you very much, Team Lupin.